Thank you. Right, let's get that out of the way. All right. So as we get started this morning, again, just another welcome in. We appreciate having you here. We enjoy seeing everybody. We're just going to go through some housekeeping items, and then I'm going to turn it over to one of our favorite presenters. Um, He's been with us a couple times, so we have another great session today. Our session today will be on the impact of stigma and recovery within professional communities. My name is Amanda Cura. I'm the Regional Project Manager for Great Lakes ROTA-RC, and I'll be your host this morning or this afternoon, depending on where you're joining us from. So again, thanks for being here with us today. We just want to make a quick acknowledgement of our funding announcement, or our funding acknowledgement. We are a SAMHSA project. We are a technical assistance center for the rural communities of HHS Region 5. The states are listed there along with our website. Let's just take a minute now to look at our website real briefly here. We've made some amendments and adaptations to the training version of our website. So we hope after this event that you'll go check that out. You'll be able to more easily access upcoming education and post-event resources. So please let us know how you find that and if it's working better for you, if you're enjoying it. In addition to that, we have opportunities for finding funding announcements, getting to community toolkits and resources, and being able to access technical assistance from the center and through our state offices. Our newsletter comes out twice a month. It highlights what the upcoming trainings are, some experts to follow, connection to our partners. We strongly encourage that you set yourself up to be able to take a look at our newsletter and to auto get that. If you need help with that, please feel free to contact me during this session or afterwards, but we'll be providing the links for you to do that towards the end of today's session. And then we just want to remember to create a space that promotes the use of affirming person-first language when we're discussing behavioral health disorders. So we want to engage in non-stigmatizing, recovery-oriented language that can really help reduce that negative bias and promote successful engagement in treatment and recovery. And with that, we formally welcome you into the Great Lakes ROTA-RC virtual learning community. Let me introduce you now to Dr. Alec Ellswick, who joined the Department of Family Services in 2020 as an assistant extension professor for substance use prevention and recovery. He began his journey with the department as a graduate student in 2015. Currently, Dr. Ellswick is a co-founder of the Lexington-based nonprofit organization called Voices of Hope, and he's a tireless advocate for people with substance use disorder. He works to promote long-term recovery by providing education in the community, reducing stigma, and studying the effectiveness of recovery support services. And with that, I'm going to hand it over to Dr. Ellswick now to provide our presentation.
Thank you so much. Good morning, everybody. I see in the chat folks joining from all over, which is always really cool. And I see folks talking about the weather a little bit too. Hopefully everybody's safe and sound. I'm reporting live from my home office in Lexington, Kentucky, and we got wild weather last night. My phone was blowing up with the tornado alerts and all that kind of stuff, but it just looks like some downed trees out there. So I think everybody's safe. So good morning, I guess good afternoon actually from me because it's afternoon. And before I say anything else, let me say thank you all for, if you signed up for our initial webinar back in December and you made it to this webinar in April, thank you for that. We were originally scheduled in mid-December and I had a 2.5-week-old, 3-week-old child, and then I caught the flu. And I'm not exaggerating to any of you when I tell you it is truly the sickest that I have ever been without hyperbole. And I had a 3-week-old. So it was not good. I was very grateful to Amanda for her willingness to adapt on the fly. And so I was glad for a chance to reschedule this. As you kind of heard in my bio, my name's Alex Ellswick. I'm an assistant professor at UK and an extension specialist. And so I get to do some original research on recovery and on stigma and on harm reduction. I get to teach in the classroom, but definitely my favorite part of my job is this, is getting to go out and interact with professionals and interact with providers and Translate the science. The research shows it takes about 17 years for research to get translated into practice. And that's a pretty big bridge, especially when 100,000 people are losing their lives a year to substance use, to overdose. So, in a lot of ways, I really do see my job as important to fill that gap and to try to help improve all of our practices. And I'm especially excited for this topic because, to be totally candid with you, it wasn't my idea. This was totally an idea that Amanda approached me with, and it's brilliant. And it's brilliant because so often when we talk about stigma related to substance use and substance use disorders, we're thinking about the people we serve. We're thinking about our beneficiaries, the people to whom we provide services. Oftentimes what we're not thinking about is the very real reality that so many of our colleagues are themselves people in recovery, that so many of the professionals we work with are people in recovery. It's actually because of stigma in part that we ignore that fact. And so just putting a spotlight on that, I thought was really a great idea, and I'm glad for the opportunity. So quick overview of where we're going to go. I'm going to give you a little background on myself, and then we'll kind of jump in with a broad overview of stigma. We won't spend too much time there. I'm guessing because of your all's work in this space, you're pretty well aware, but sometimes a deep dive can be helpful. And then I'll share some personal experiences that I've had with stigma in professional settings, share kind of some of the general research and some of the other experiences that I've gleaned of stigma among professionals. And then I wanted to spotlight for a little bit specifically peer support specialists, a specific kind of professional, and the stigma that they experience because peer support, peer workers, recovery coaches, whatever nomenclature you use is a role that's exploding across the United States in behavioral health services. So um, it's a type of professional in recovery who's experiencing a disproportionate amount of stigma. And then we'll talk about some strategies for addressing stigma. So if you've joined me for one of my other webinars before, you probably know that I can't resist the urge to share a little bit of personal experience. And it's honestly not because I'm egomaniacal or whatever. It's because as I'll tell you later on, research shows that this kind of contact-based strategy is actually the single most effective way to reduce the stigma associated with substance use and substance use disorder. There's actually a multitude of studies that confirms that. And so one way I look at this is if the hour that you spend with me isn't all that helpful, and if I don't drop a bunch of wisdom on you, that's okay, because as long as I engage in this practice right here, I know that I've done something that's effective. So it feels like a fail-safe for me. So really quickly, I won't spend too much time here, but I am from Lexington, Kentucky, born and raised. And every time I share this personal experience, I start by telling people, man, I grew up really privileged. And I don't say that because I'm looking for brownie points. I say that because it's true. I grew up in the suburbs. I went to private school. My dad's a doctor. My mom's an accountant. Nothing bad ever happened to me as a kid. I wasn't neglected or abused. But I inherited some risk factors, a genetic predisposition for addiction, ton of addiction in my extended family. And then, I've struggled with anxiety disorders from the time that I was pretty young. And so when I was 18 years old and I got prescribed, this is 18-year-old me, by the way, just to humanize it for you a little bit. You're welcome to laugh wherever you are. I think I was going through a real identity crisis there. Um, when I was 18 years old, I got the chance to go play college baseball and I was kind of living my little dream. And then I had surgery to have my wisdom teeth removed and I got prescribed oxycodone. And I took the medication exactly the way that it was prescribed by my provider. But I actually got dry sockets in the four wounds in my mouth. So they gave me a second script for oxycodone. So I ended up with like a 30-day supply of opioids for a pretty minor outpatient procedure. And I got addicted. Um, and for the sake of time, I'll just tell you that addiction took me, my substance use disorder, took me in and out of jail on drug possession and drug trafficking charges, took me in and out of treatment and in and out of treatment and in and out of treatment. And man, did I try so hard to stop. I can't tell you the number of times that I checked into a 30-day treatment center and did everything within my power to prepare myself for success. And then on day 31, I would get out and I would relapse like that, like I had no power and I just couldn't understand. And so I ended up experiencing homelessness in a few different cities in Nashville, in Lexington, in Cincinnati, and then finally in Dayton, Ohio. This is Highway 35 overpass that runs through downtown Dayton. And by then, I had made the transition to injecting heroin, and I was panhandling and holding a cardboard sign by the on ramp that said homeless and hungry, and really living out a stereotype in a lot of ways of substance use disorder. And I met a community of folks who were also experiencing homelessness and who also were IV drug users, and they showed me, I should say, they were also people who use drugs, and they showed me the ropes, like where to go to get a meal and where to go to get a shower, and they told me about a Salvation Army, which is a homeless shelter there in Dayton, Ohio, and that's where my recovery began September 13th of 2013. And I ended up spending 6 months of the hardest, doing the hardest work of my life at the Salvation Army. And when I got out, I just had a tremendous amount of help um, in accessing recovery capital and accessing the resources that I needed to build a kind of sustainable recovery. And I really think that explains why I get to be where I am today and why I get to do what I do today. So I'm so grateful for the chance to be able to use that experience to stand up and to say it out loud. You know, their 12-step programs have been a mainstay in treatment and recovery. Programs based on anonymity have been a mainstay for a long time, and they're tremendous programs. But one of the downsides of anonymity is that it really limits the visibility of recovery. That we don't have people who are standing up and saying out loud, you know, my name's Alex, and I used to have a problem with an opioid use disorder, and I don't anymore, and I'm in recovery, I'm in remission, and this is what that looks like, because that's so powerful at changing people's attitudes and people's understanding of addiction and recovery. So I think we'll talk some more about contact-based strategies at the end, but that's a little on an experimental basis, just a little attempt for me to say this was my experience, and that's not everyone's experience in addiction and recovery, but at the very least, hopefully it helps humanize it a little bit. Um, there's my sweet mom and dad. I'm just going to skip over some pictures real quick. That's a bunch of our staff at Voices of Hope, like 2015. So cool stuff. All right. So what is stigma? What is stigma? On one hand, it seems like a silly question because we're all here probably because we're well aware of what stigma is, that stigma exists, et cetera, et cetera. But sometimes I think it's helpful to get a clarification because sometimes stigma is this ill-defined, abstract thing up in the ether that we know is bad, but we don't exactly, it's not tactile and tangible. We don't know exactly what it is. So if you just wanted like a Merriam-Webster definition, stigma is a mark of disgrace associated with a particular circumstance, quality, or person. Um, and it's interesting that even today in like a Merriam-Webster definition that we use the phrase a mark of disgrace. And I'll say some more about that in a moment. Um, Irving Goffman in the literature is considered like the father of stigma and stigma science. And he talked about stigma as a stigmatized identity as a spoiled identity. And more recently, other researchers have used the characterization of stigma as socially discrediting. And for my money, I like that characterization the best. I think it offers the best reflection of what the real net effect of stigma is, which is to socially discredit the individual or individuals who are stigmatized. And I'm a big nerd and I can't help it. And so I love thinking about the etymology of words, how the origin of words and how their meaning has evolved over time. And it's really interesting. It really gives you a deeper understanding of meaning. And the word stigma, the prefix stig or stigum comes from the Greek for a tattoo or a brand. And as far back as like ancient Roman times, people who committed criminal acts might be branded as a way to, number one, readily identify them, perhaps, as a form of protection or deterrence, but also as a way to shame them, right? As a way to socially discredit them, to say this is a criminal and a person who should be avoided and not trusted. And more recently, during the transatlantic slave trade, when um, people who were enslaved would try to escape and would be captured, sometimes they would be branded with an R on their cheek to signify that they were a runaway, right? And in that way, it's an identifying mark, but it's this physical mark that's socially discrediting. It's a physical mark, and today, stigma has evolved, just like the use of the word stigma has evolved. What stigma looks like has evolved. And we don't brand people anymore, thank goodness. We don't tattoo people that way anymore, thank goodness, at least not here in the United States. Um, but we do stigmatize people. We do figuratively brand them and figuratively label them. And in some ways, I like to include that etymology because it helps remind us that when we talk about stigma like it's just a label, it feels like it's one of those sticky notes you put on your chest at a conference that you can put on and take right back off. And that's not what stigma is. Stigma is much more akin to something that's branded onto you and without your own permission, right? And then there's a picture of the Scarlet Letter, if you're familiar. I don't know if that was like required reading for us all in high school or just in my curriculum, but we had to read the Scarlet Letter. Then the protagonist commits adultery and she's forced to wear a scarlet A on her chest, and that's a stigma. That's a physical marking that socially discredits her. And so again, today we don't physically mark people, but stigma is no less marking in that sense. It's no less of a label of a brand that discredits people. And it's important to know that substance use stigma is the greatest kind of stigma that exists. And that sounds like hyperbole, or that sounds like just a subjective value-based statement, and it's not. We actually have empirical evidence that supports that. The World Health Organization did a study about 15 years ago comparing stigma associated with different disorders and different conditions. And they found that illicit drug use disorders are the most stigmatized public health condition in the entire world. And alcohol use disorders, more particularly, were the fourth most stigmatized health condition. So they rated as more stigmatized than sexually transmitted infections and HIV. So that's important context. We all came into this conversation going, yeah, we know that stigma is a problem. We know that it's everywhere, but there is no condition, there is no identity who experiences more of the kind of tragic stigma that we're talking about than people who use drugs and people with substance use disorders. And not only is stigma abound in terms of degree, but it's also everywhere. So research shows that stigma is really high among the general public, which, oftentimes we attribute to their lack of understanding, ignorance in a sense, just kind of a forgivable kind of ignorance. But research also shows that stigma is high among professionals who interact with people with substance use disorders. To be frank, I mean, not at all pointing the finger because that includes me, but I think that includes many of you as well, right? The reality is we all have implicit biases, we all have blind spots. That's what a lot of the literature has shown us over the last 10 or 20 years. No matter how well-meaning, no matter how pure our hearts and our intentions, that many of us hold stigmatized views about people who use drugs. Even people who use drugs themselves hold incredibly stigmatized views of people who use drugs. Sometimes that despite their experience are informed by misconception and misinformation. So the point being, stigma around substance use is everywhere. It's incredibly problematic, and it's incredibly harmful. And so I wanted to start just by sharing some personal experiences that I've had with respect to stigma in professional settings. And the first one is my exemplar example. It's my best example because it's the first that I experienced in a professional setting, and it's the one that set the table. It's the one that, to be honest with you, that put me in my place. which in some ways is what stigma is intended to do, right? To socially discredit. So I started as actually, as you heard in my bio, I started as a graduate student at UK in 2015. And I was about a year and a half in recovery from an opioid use disorder. I was also about a year and a half out of homelessness. And so I was rough around the edges. I smoked cigarettes. None of my peers in graduate school would dare smoke a cigarette, right? Because they're educated and informed, and they don't have a substance use disorder. Um, they they had all. I remember the first day of class when we were supposed to talk about our favorite theory, and I didn't even know a name of a theory, and every one of them knew all these theories, you know. So I say all that to say I was coming to graduate school with some serious imposter syndrome, and some of it rightfully so, because I was at a disadvantage relative to my peers. I was behind in some respects because of my addiction. And the weekend before I started my graduate work, our nonprofit had been in the local paper on the front page of the Herald Leader for in recognition of an event that we'd done for International Overdose Awareness Day. And the reason I mentioned that is because then the Monday after that weekend, the Monday after that was written in the paper, I walked into my first day as a graduate student to work with a professor, and another professor at UK came to her and brought a copy of that Herald Leader article with a picture of my face and said, and asked her, "Have you seen this?" As if to say, "Are you okay with this?" And then she went on to say, um, "Are you worried about your safety?" And number one, never ever will I name this person, because despite that interaction, I still hold a tremendous amount of respect for this person. Um, but but I'll tell you that what was problematic about that experience and the stigma that I experienced was not that it hurt my feelings, not that I was traumatized by that experience, but that I learned immediately that I was in a one down position relative to all of my peers. That on my like virtually my very first day in graduate school, what I learned was I have something to prove. I have something to overcome every single day, because where my peers get to show up and just be their full authentic selves, I can't, because at the same time, I have to be proving that I'm not a threat to the people that I work with. And it's just one example, and it's really easy to see things like that and to think, okay, so they said something that hurts your feelings. That's not what we're talking about. Yes, part of the stigma, part of the effect of stigma is, the emotional and mental harm that people experience. But what I'm talking about is psychologically, the way that um, it rendered me a little lower in the hierarchy. And then part of the reason I would argue that stigma is still that there's still such a great degree of stigma among professionals is because so much of the training that professionals receive is either inadequate or itself stigmatized. And so one really clear example of this that comes from my own experience is when I was in graduate school at UK, also, I wanted to take every course that I could take on substance use. So I went into I wanted to learn everything I could. So I went to the course catalog and I typed in addiction and substance use and all those different things. And I took classes in pharmacy and social work and psychology and wherever. And the only course in social work that's offered related to substance use, in fact, it's the required course for all social workers to be who will graduate the university. At the time, the course was called Substance Use, Violence, and Risk Management. Now, granted, the reason that class is structured the way that it is probably partly a consequence of curriculum restraints. If you've ever been on like a curriculum committee, then especially for social work credentialing, probably they had to pack those two things together and address violence intervention and substance use. And I suppose I understand that. But the point that I'm making is every single social worker who's being educated at the University of Kentucky is being taught about substance use only and exclusively in the context of its relationship to violence. And that's inherently stigmatizing. That's inherently problematic. It means The sum total of these social workers training around substance use is implicitly suggesting that there's going to be a lot more violence than there is. And that comes with a whole host of problems. And so I think in some ways the structure of that course has since changed. But it's just an example of the ways that that stigma becomes perpetuated among professionals. And then really quickly, one of my favorite examples, just because it's funny, um, we'll talk about language at the end today because it's one of the most effective strategies for reducing stigma. And I was at a rural community in Scott County, Kentucky, kind of just outside of Lexington. And I was at a community coalition in 2017, and there were police officers and first responders and physicians and all, these judge executives and everybody talking about the drug problem and those people. And there was so much, even though I know everybody meant well and I know their hearts were in the right place, there was so much stigmatized language being used that I thought, hey, I'm going to use this as my opportunity to advocate. And so when it was my turn to get to the microphone, I stood up and I shared something that I'll share with you all in a little bit, some research on language. And I thought, oh, I'm such a brilliant advocate. I was breaking my own arm, patting myself on the back. And then the next day, the local paper published an article that could not have used more stigmatizing language. Ex-addict warns about narcotic problem. In fact, the study that I shared and that I share with you all later on specifically asks you not to use terms like ex-addict. And I guess that the reporter didn't catch the message. So it turns out that not all of my anti-stigma efforts have been really effective. So how do professionals experience substance use disorder stigma? And um, by the way, in preparation for this conversation, in addition to looking through literature, one of the things I did is sit down with some colleagues who are professionals in recovery to ask about their experiences. And that's both professionals who work in the substance use disorder treatment and recovery space, but also professionals who work in other spaces, one of whom is a surgeon. And they had some really interesting things to say. One of the things they talked about was interpersonal barriers, that they don't get the benefit of the doubt. And I think in part, this is what I was trying to share in telling the story about the professor with whom I interacted at UK. That what I learned was I don't get the benefit of the doubt. My peers in graduate school can show up to class and they can be sleepy and they can be tired. And we will all attribute that to the fact that they were up late last night studying really hard because their studiousness, right? If I show up to class sleepy and tired, and I exist at the intersection of sleepy and tired, and I have a substance use disorder, then the people are going to make the attribution perhaps that I'm nodding off, that I've taken opioids, that if I become disgruntled and I become upset, if my peers become upset, it's because they're under a disproportionate amount of stress. Because hey, a clinical graduate program is really difficult. If I become angry and I become upset, um, it sort of translates to I'm doing something wrong in my recovery. And I think this is one of those fine lines. Gorski and some of the research on relapse prevention would suggest that, a relapse or a return to use is something that happens in your mind quite a bit earlier, like a psychological process, quite a bit earlier than the physical action. And what's problematic sometimes about that is that it makes us say, well, if you're having a bad day, then you must be doing your recovery wrong. And that's to say that people with substance use disorders, professionals in recovery, don't get the benefit of just having a bad day like all of our colleagues, not because we're not taking care of our recovery, not because we're not mentally or spiritually fit or whatever, however you want to kind of, right? Because we're humans. And because, like all other humans, sometimes we get anxious or upset or have a bad day. And sometimes then the check-in that comes from colleagues, are you okay? Is really a coded way of saying, have you been using drugs? And again, I'm not trying to point fingers. That's my goal is only to be helpful. But I've experienced this, and more importantly, I've been guilty of this, and I've been guilty of this very recently. And so I wanted to share this experience in particular so that you all know that I'm not like dogmatically shaming anybody for, things they say or do. Um, I'm definitely guilty of it all. I've put my friend Amy in quotations because it's a pseudonym. I wanted to protect her identity, but we had a staff person who is one of our most dedicated staff persons. She's a person who's been in recovery for probably 6 or 7 years. She has been a rising star at Voices of Hope as she started as a coach and then moved up into a program coordinator position. In that time, she met a man she loves. She got married. She bought a house. I mean, she's living all of the dreams of recovery. And she became pregnant and um, experienced a miscarriage 8 months into her pregnancy. And it happened to be almost, by the way, just incidentally, about the time that my own wife was considerably pregnant. And the first time that I had a meeting where I was able to interact with some of our staff after that news had come out, she was out of the office and I asked them if she was doing okay. And upon reflection, even though this isn't what I said, what I was really asking was, has she relapsed? And that so is not a reflection of at least what I wish was on my heart. Because what I wish I would have said to her was, uh, or what I wish I would have asked about her was, is she actually okay? How is she doing? What support does she need? How is she feeling? If someone with any other kind of condition experienced a miscarriage, our first concern would only be their health and well-being. It would not be their drug use. But that is part of that insidious stigma of drug use. And so I try to share a few of those examples from where sort of I'm the perpetrator, if you will, of stigma because we're all guilty of it. And it's much more helpful instead of pointing fingers at all these bad actors in the community. It's a lot more helpful for us all to adopt this perspective that like, hey, we all do this a little bit. Maybe to different extents, but we all do it a little bit and we all have a role to play in reducing it. And then in addition to interpersonal barriers, people who use drugs, people with substance use disorders, people in recovery, however they identify, experience really meaningful structural barriers to housing, to employment, to all kinds of things. But professionals in particular experience a distinct form of discrimination. And so, one example that's kind of a jarring example comes from my community. We have a community paramedicine program, which is I would be willing to bet that most of your communities have something similar. Sometimes they're called QRTs, quick response teams. They're multidisciplinary teams of first responders, social workers, and most often a peer who follow up after a non-fatal overdose, as a way to try to take advantage of that point of contact, connect people to resources, harm reduction, and treatment. And best practice, guidance would suggest that those interventions include a peer, a person with lived experience, because they're going to be able to rapidly build rapport with people on the ground. You really need someone who has that kind of sensitivity in order to connect following a non-fatal overdose, which is a particularly vulnerable and sensitive period in a person's life. And so my friend Jeremy, my friend and colleague Jeremy, who is a well-known recovery advocate in my community, he's been doing this work for a long, long time. He's very well respected. Um, was a peer on one of those community paramedicine units, and he was having a friendly conversation with one of his colleagues on the unit, where he was sharing some of his personal experience, some of his own criminal history. And on a whim, that colleague decided to go and look up his background, saw that one of his charges included a form of violence, and decided that he didn't want to work with him anymore. And and Jeremy no longer works with that intervention. And the reason I wanted to give you this example was to share with you an example of how stigma doesn't just negatively impact that individual. I mean, make no mistake, Jeremy was negatively impacted by that. But that has negatively impacted my entire community. My entire community, everyone in my community who uses drugs, everyone who's at risk of a non-fatal overdose, who might have benefited from the rapport and the love and the compassion that Jeremy can provide that these other folks can't. That's a real shame, and that's a real consequence of stigma. And along those lines, my friend Jeremy likes to say, he likes to remind us sometimes that sometimes when we're talking about stigma, we mean stigma. And sometimes when we're talking about stigma, what we mean is discrimination. And the reason that's important is because stigma is a bad thing, but it's non-binding. Discrimination is a legal term. It's illegal to discriminate, and people with substance use disorders are protected under the ADA, the Americans with Disabilities Act. And so it's a way of kind of raising the level of alarm. Sometimes we say stigma, and what we mean is people are being discriminated against because they have a substance use disorder that is entirely outside of their control. And then broadly, one similarity that all of the professionals talked about that I wasn't exactly sure how to summarize, like as a theme, but basically the inescapable assumption that something's wrong with you. And I kind of waffled back and forth on whether or not to give this particular example because this example itself is kind of stigmatizing. I'm afraid it perpetuates stigma, but my hope is that it also reduces stigma. Um, I have a colleague and a friend and a guy I went to treatment with who had a really bad alcohol use disorder, a severe, we should use the clinical term, shouldn't we? A severe alcohol use disorder. And he just so happened to also be um, one of the most brilliant and respected surgeons around. And when he was in treatment, while I was in treatment, when we intersected together, at one point he got in trouble because he was collecting Kool-Aid packets so that he could mix them with hand sanitizer so that he could drink it for the alcohol content. And I realized that sharing that is a very stigmatized example to share. And normally that's the kind of thing I would omit because that's not helpful. All that does is perpetuate more stigma. But here's the point that I want to make to you. The same man whose substance use disorder is so severe that he would engage in that type of behavior is also the single most qualified person to save your child's life in surgery. And that's just a matter of fact. And so it's for so many of us, what stigma does is create this one dimensionality. It flattens people into that label. And we go, oh, well, if you're an alcoholic, to use the stigmatized term, then you couldn't possibly also be a competent surgeon. And that's not to say that he was a competent surgeon while his alcohol use disorder was active, but certainly as a surgeon in recovery, he's the most sought after. And along the same lines, I guess I just would share my own experience, which is when I was sleeping under Highway 35 in Dayton, um, again, stigmatizing as this is to share, I could not stop injecting myself with heroin. I really couldn't. Um, I just I just couldn't stop. And yet, if you had sought me out and said, "Hey, Alex, I know you took class on, took math all the way up through calculus in college. Could you do some calculus right now?" I guarantee you, I bet you my bottom dollar, I could have successfully done some calculus. I think if you'd said, "Hey, Alex, I know you studied Western political theory when you were a little younger. Would you debate Western political theory with me?" I don't know why you would have done that with a person experiencing homelessness. But my point in kind of giving you this absurd example is what we know about the neuroscience of addiction in the brain is that that executive functioning part of the brain is not the part of the brain that's impacted. It's the limbic system. It's this much more primitive part of the brain. And so at the same time that a person can have a severe substance use disorder, they can be intelligent, competent, and capable human beings. And it's that inability to accept both things at once that can make stigma so harmful for professionals, so discrediting to professionals who otherwise might be your most qualified and competent colleagues. And then I told you I wanted to just say a little bit specifically about peer support specialists. I don't know if anybody on this call, if we really had any reach out to peer workers, but you all may call them different things in your space. Sometimes they're peer workers or peer support specialists. or peer mentors or alumni advisors or recovery coaches. Big long list of names. At the end of the day, what all of these things have in common is that they're peer based. So instead of it being a person who is um, a clinician or a social worker or a marriage and family therapist, instead, what we have is a person whose main credential is their lived experience. And because my Voices of Hope, because our nonprofit is peer based, all of our staff are peer support specialists, peers. Um, I have a lot of experience with peer workers and have done a little bit of research on peer workers. And um, we know that peer support in general has been around a long time. People have always sought help in groups, but these more formalized models, professionalized models of peer support are a little bit newer, a little bit more of a consequence of the recognition that, hey, this is a chronic disorder. And so we need more models of long-term prolonged engagement, which peers can provide and which treatment providers cannot provide, right? Or at least which peers are better positioned to provide. And so, as a consequence, and this is really outdated now, in 2019, a quarter of all behavioral health facilities had peer support. Today, that number has almost certainly grown. And yet, peers experience a unique kind of stigma. So, not only do peers experience stigma because, as their job title, kind of implies and betrays, they necessarily are people in recovery, and that identity is baked into their job title, right? But they also experience stigma because people don't understand their role. And so this comes from some research we did recently, really where we were focusing on enhancing role integrity for peer workers. But some of what came out of our findings has to do with the way that professionals experience stigma. And so that's why I wanted to go here. So for any of you who work with peers, maybe this is helpful context for you. Peers play a very specific and important role. And yet that role is not to be sort of like a therapist. Their role is not to be sort of like a sponsor or sort of like a drug and alcohol counselor, or, they may bear some similarities to all of those roles, much in the same way that a social worker and a marriage and family therapist might bear similarities in their roles, but they're different roles, different training, different certifications, right? Different aims. The same thing is true. Peer support is a different thing. It's intended to do something different. They're not supposed to be junior therapists or therapists who are just less credentialed. And unfortunately, so often in behavioral health settings, that's what they're understood to be. Because organizations don't fully embrace exactly the efficacy and the foundational theory behind why peers are so effective. Instead, they get treated like therapists who just aren't as educated. And so they get paid less and they have to do worse jobs. And so this is a lot of words on the screen, but this is more to the point. So in the infancy of emergent peer support models, some researchers warned of external threats to the integrity of the peer worker role. So William White, who's one of my very favorite authors and addiction recovery thinkers, in 2006, he identified the overlap with among peer support and addictions counseling or mutual aid sponsorship as potential sources of encroachment. So again, just acknowledging that there are all of these roles that are adjacent, that are similar, but that are designed to do something different. And so he went on to say, if it's to survive, a new service role must stake out its distinctive turf and justify its existence, and it must do so in the context of other roles which claim the same or adjoining territory. And so the point here, as White explains, is that peer workers emerged in response to a need for a new type of peer role that fills gaps in the continuum of care, which cannot be addressed by addictions professionals. Peer workers have more diffuse boundaries. They're therefore better able to build rapport and provide close contact, continuous recovery support. The point here is peers are designed to do something different. You can't make a social worker be a marriage and family therapist. They're not the same thing, right? The same thing is true here. And so then when we asked peers about their experiences, One of the things they talked about is this dissonance between the role that they understand they're supposed to be playing and the tasks that they were assigned to do. And so, when asked what tasks they performed as a peer worker, participants reported being asked to do, quote, everything. Everything from doing the case management jobs to doing the admin jobs to being the janitor to being the case manager to peer support, literally everything. Asked to do everything with little pay, always the lowest paid person in the building, always asked to be the one to take out the trash, to pick up the cigarette butts while other people basically weren't doing anything. That's kind of what we had to deal with. And I found it noteworthy that another participant reported almost verbatim the exact same thing when she was talking about being treated like a second class citizen in the workplace. And she said, well, the clinicians asked our peer support specialist to empty the trash cans when we first came on board. So, really clear indication that the clinicians, the therapists with whom these peers were working did not understand, and more importantly, did not respect their role, didn't respect the value of their lived experience, respect the unique nature of the role that they provided. Instead, they said, "Oh, you can do some of these case notes, or you can take out this trash. You can just do the low hanging fruit because you're not qualified to do what I'm qualified to do." And so, in that respect, these professionals who are in recovery are experiencing dual stigma because not only are they experiencing the stigma that they might be experiencing just by virtue of being in recovery, the general stigma that that professionals in recovery experience, but then they're also experiencing this stigma of their profession because their professional role as a peer support specialist is being stigmatized. And part of the reason that peers are particularly vulnerable to stigma is because they exist at this really unique intersection. Or if you want to use a different analogy, they have to walk a crossroad, a clothesline, a crossrope. What am I trying to say? They have to walk a tightrope. That's what I'm trying to say. My goodness. They have to walk a tightrope between being a peer, which means in order to be a peer, you have to be like the people you're trying to connect with, the people with whom you're trying to serve, which means I can't be so professional. I can't be wearing a suit and tie to work every day and speaking in super scholarly language, or I won't be able to build rapport with people, right? I won't effectively be any kind of a peer. But at the same time, these peer support specialists, as the term specialist would imply, are becoming increasingly professional roles and being introduced to increasingly professionalized environments. And so they're being asked to be socialized to professional settings and to have an expert posture. And so, to that end, one of our participants said, the biggest issue they have with me is this makes me laugh. The biggest issue they have with me is professionalism. So they teeter-totter me. Yes, you need to do your job. Yes, you need to be you. Yes, you need to share experience, strength, and hope. Oh, now you need to be a professional. And that's really problematic. In other kinds of literature, you might kind of think of this as code switching. It's basically the role that peers are asked to play on a regular basis is to code switch. That we have to be able to maybe curse a little bit, maybe talk a little bit of lingo, maybe, speak the language of the people we serve. And then immediately after walking out of that interaction, peers have to walk into an interaction with a treatment team where they might have to use more clinical language. And that's really challenging. It would be challenging for anybody to do that. But the reason I bring it up here is because that's part of what contributes to the stigma and contributes to them being socially discredited, is when therapists and other providers on the treatment team look at them and judge them by a therapist standard instead of a peer's standard, then they say, oh, yeah, they're not meeting this professional standard of conduct. When in fact, they might be fulfilling exactly the standard of conduct that they should be in their role as a peer. And another participant in our study went on to say, I never had a job in the corporate world, like an office setting, those kinds of things. So I really had to curb myself into that kind of lifestyle. And I like to emphasize this particular way that stigma, that professionals in recovery experience stigma because lack of experience or lack of exposure is sometimes misunderstood as a lack of competence or a lack of ability. Or a lack of professional socialization is sometimes mistaken as a lack of ability or a lack of competence. And I see this all the time with the peers we hire at Voices of Hope, who are wonderful, hardworking, earnest, competent people. And yet, sometimes the emails they send are just kind of inappropriate, you know? And that's not a dig. I'm not making fun of them. It's not because they're stupid. It's because they're inexperienced. It's because they haven't had the benefit of spending a decade in professional communities like I have, where I've read tens of thousands of emails, so I know how to send a salutation and a greeting and sincerely or best Alex as we like to use in academia or whatever, right? This can be taught. And so I think sometimes what stigma does is we attribute that to their competence or their intellect or perhaps even to their drug use, something that should instead simply be attributed to a lack of experience. So we're running down to just a few minutes left. What can we do about stigma among professional communities? And the first thing that we can do is language. This is, I love every time I get to share this example because I think it's so interesting. Um, you all may know that in some languages, articles are gendered. So, like in English, if I say the cat, the word the isn't masculine or feminine because we don't gender our articles. But in Spanish and German, so like in Spanish, if we say the cat, el gato, el is a masculine article, right? And the reason I'm sharing that with you is because these researchers at Stanford did this really cool study where they gathered together a group of native German speakers and a group of native Spanish speakers. And they showed each of these groups of people the exact same picture of the exact same key, okay? And when they showed this key to the German speakers, they asked them to describe it. And I'm going to butcher some pronunciations because I don't speak these languages, so forgive me. But in German, the word key is something like der Schlüssel, and der is a masculine article. And so when they asked the German speakers, how would you describe this key? The German speakers described it as jagged, rough, hard, heavy, and metal. Very masculine terms. But then they showed the exact same picture of the exact same key to Spanish speakers, native Spanish speakers. But in Spanish, the word key is la llave, and la is a feminine article. And so when the Spanish speakers were asked to describe the key, they described it very differently. They described it as intricate, little, shiny, tiny, lovely. Mind you, they were looking at the exact same picture of the exact same key. And yet, these descriptions are almost completely opposite. The German's description seems a lot more masculine, and the Spanish description seems a lot more feminine, right? And so, if you're following, if you've kind of picked up on what's happening here, they give another example, which is a bridge. They showed a picture of a bridge to native German speakers, and in German, the word bridge is die Brücke, or die, I think die Brücke. DIE is a feminine article. And so when they asked German speakers to describe the bridge, they described it in these really effeminate terms. They said it's beautiful, it's elegant, it's fragile. We have a fragile bridge, we have a problem. Then they show the exact same picture of the exact same bridge to Spanish speakers. But in Spanish, the word bridge is el puente. El is a masculine article. And so when they ask the Spanish speakers to describe the bridge, I bet some of you can already guess, they described it in really masculine terms. They said that bridge is big, dangerous, long, strong, sturdy. So just imagine for a second, just to drive home this point, that there's a native Spanish speaker and a native German speaker, and they're standing shoulder to shoulder on the riverbank, and they're looking at this bridge. And one of them says, in their native tongue, I suppose, man, that looks like such a strong, sturdy bridge. And the other one says, no, that looks fragile to me. How can that be? How can it possibly be that they have these completely opposite views? And the answer is language. That what we're getting at here, what this example shows is the power of language. What was different about the bridges or the keys wasn't what they were actually looking at. They were looking at the exact same thing, but the reason that they described them differently is because they were perceiving them differently as a consequence of the different language that was being used. So this is called linguistic relativity. It's just a fancy way of saying that language really matters. Language really impacts the way that we experience things. Language can make whether we call a bridge El Puente or whether we call it Die Brücke, makes it feel stronger or weaker based on language alone, right? And the power of linguistic relativity is especially important when it comes to any vulnerable population, especially people with substance use disorder. So back in 2010, researchers created this hypothetical short story. So they made up this scenario about a man named Mr. Williams, and they said, "Hey, Mr. Williams is in a drug court program, and he tested positive on his urinalysis." And so they asked the question, "What should we do with Mr. Williams? Decide his fate. Should he go to treatment or should he go to jail?" And they gave this survey to a bunch of mental health professionals, people who probably understand addiction pretty well. And all of the vignettes or the short stories that they handed out were word for word identical about Mr. Williams. The only difference was that in half of the short stories, Mr. Williams was described as a substance abuser who tested positive. And in the other half, he was described as a person with a substance use disorder who tested positive. You catch that? I mean, that's almost a seemingly insignificant difference, but it turns out that it's a profoundly important difference in language because the mental health professionals who received the short story that said Mr. Williams is a substance abuser were more likely to send him to jail. And the folks who received the vignette that said Mr. Williams is a person with a substance use disorder were more likely to suggest he get an opportunity to treat his disorder. And so I love that example because it talks about the power of destigmatized language. Bridges and keys is a silly example to introduce the power of language. This is a much more ironclad empirical example that language matters. And then, as I said way back in the beginning of this presentation about the importance of stigma and the effect of stigma, it's not just about hurting people's feelings, even though sometimes that can be one of the unintended impacts. It's about the fact that it actually changes people's hearts and minds towards drugs and towards people who use drugs and towards people with substance use disorders. And the way you talk about addiction informs the way you think about people who become addicted, and the way you think about people is going to inform the way you treat them. And so I think it just speaks to why language is so important. And so I just double down. You've probably heard this at some point before. I think it's just always a helpful reminder to touch on. And I love that I had forgotten actually that at each of these ROTA webinars that Amanda and her colleagues give us that initial reminder to use person first language and to use destigmatizing language because research shows it's among the lowest hanging fruit that we have at our disposal. And I know that I'm down to like 2 minutes, and I promise we can get there. Last kind of evidence-based strategy that I wanted to touch on are contact-based strategies. And of course, I gave you my own personal example of that by sharing some personal experience. But it's not only is it the single most effective approach for SUD stigma broadly, but it's particularly effective among professionals because they're so much more reticent to identify publicly that they are a person in recovery. And when professionals are reticent to identify as a person in recovery, it reduces the visibility of recovery. It limits role models, and that stigma leads to silence and prevents professionals from receiving the support that they need. So one thing that organizations can do is to be trained on what we call fair chance employment, what sometimes is called second chance employment or transformative employment, so that they vet their policies, practices, and procedures for stigma, for substance use disorder stigma. Also, we encourage ban the box measures, which probably are more accurately called delay the box because the box doesn't entirely go away. But you all may know that when you apply for a job, in some cases you at the initial application have to indicate whether you've been convicted of a criminal offense or in particular a felony offense. And that alone, in most cases, is enough to get your application discarded immediately. And so what Ban the Box seeks to do is to say, hey, have a human experience with this person first. Read their resume, sit down and have an interaction with them. You as a potential employer absolutely have the right to know if this person has this particular criminal history or this particular felony history. But can you meet them first? Can you meet them as a human being first, unfettered by knowledge of their felony or whatever it is, and then develop an awareness of that? And what research shows really empirically and concretely is just by virtue of by delaying the box, that people get far more opportunities for fair chance employment. Um, and then professionals in SUD recovery need role models. In some of the treatment centers I went to, there were dedicated support groups for professionals, which is ironic in the context of this conversation because in some ways that might reflect those professionals' own stigma towards the other folks in treatment who they think, hey, I'm not like them. So that kind of makes me smile. But also, as we say in peer support, peers need to be like the people they serve. Peers need to be true peers. And so, if creating an affinity group around professionals is part of what helps create a peer sensibility, then that's fantastic. So sometimes, there are groups for doctors and lawyers and professionals of any stripe. There was a meeting here in Lexington that was called a Rogue AA and Al-Anon mixed meeting, which I used to love. And it was a noon meeting. It was at 12 p.m. So you used to, some people in the recovery community call those brown bag meetings because you bring your lunch with you and go to the meeting. And because it was a lunch meeting, there were lots of professionals who'd attended, lots of folks who would come from downtown, from the courthouse, from the hospitals, and who would come in for this meeting. And that was a really important source of support for me and a really important buffer for me against the stigma I experienced among professionals, to see other professionals in recovery who were doing it with me. And to that end, my most visible role model in recovery was a guy named Matt Layton, who was a social worker in one of the outpatient clinics that I attended, who was a person in recovery, but he was also a social worker and a professional, but he also had sleeve tattoos. And I realize that probably sounds like a really silly and surface level reason for me to connect with somebody, but I have sleeve tattoos and I've experienced plenty of stigma as a consequence of it. And just knowing that Matt could be a true professional and such a respected member of the community gave me a genuine kind of hope and support. And I know that I'm already 2 minutes over. So, with my last 30 seconds, let me share this last. The single greatest, most effective example I've ever seen of a professional who's in recovery who used a contact-based strategy to reduce stigma was this. I went to Clemson a few years ago for a conference. I shared some research on recovery capital. One of the other speakers was there to um, talk about what at the time they were calling medication assisted treatment, what we really try to call today medication for opioid use disorder. And I was interested in particular to attend that session because, as you all probably know, medication for opioid use disorder is a particularly stigmatized pathway of recovery. It's a pathway of recovery that experiences a disproportionate amount of stigma. And so I was really curious to see how this guy was going to handle it. Was he going to handle it with care? Was he going to humanize it? What was he going to do? And to be honest with you, I was disappointed because he gave a pretty dry, pretty academic, scholarly presentation. Here's the data, here's the research. Fine, but it just wasn't moving. And I was kind of disappointed in that. And he wrapped up and he said his thank yous. And just before he left the podium, he said, "Oh, yeah, I forgot one more thing." And he put up his final slide. And his final slide was a picture of him sticking his tongue out, putting buprenorphine on his tongue. And it had a time stamp from that morning. And he said, "This is a picture of me taking my buprenorphine this morning. I am a person on medication for opioid use disorder, and I've been in recovery for 12 years." And he turned and he walked off the podium. And I am just here to tell you that I don't know if he knows it, but that's the greatest mic drop moment I think I've ever experienced. That's a contact-based strategy. In giving that kind of dry, kind of scholarly presentation, he was, sort of just establishing credibility as a scholar and an academic. But the moment that he said, "Look, I'm one of these folks too," I have to think that, like me, everyone in that room immediately changed their attitude towards those medications. So, really, really cool example. I know we had to move quickly because there's always so much to share, but if we have time, Amanda, for questions, I'm happy to stick around and take some. And if not, I also offer up my email. If you want to access resources or just kind of continue a conversation, I'm happy to connect with folks that way as well.
Thank you, Alex. Since we are just a little bit past the hour, I know everyone enjoys hearing Alex presentations and just the events that we provide. We've gone ahead and popped the post-event survey into the chat as well as our contact information. So if you please take a few moments to complete the survey, it helps us give Alex and all of our presenters feedback on how you've enjoyed the sessions, and it helps us decide what other events to do in the future. And certainly get in contact with us if you'd like to learn more about this and other events. I'm going to go ahead and stop the recording, but please feel free to stay on and